Hello from America. I'm Arnold Seto from the Long Beach VA Medical Center, and I'd like to thank Jos for inviting me to be part of this session. I'm going to be speaking about pre and post PCI physiological assessment using a dedicated monorail microcatheter from ACIST, the ACIST catheter. These are my disclosures. And as we know from our experience, there are many options for hemodynamic assessment in this modern era. Traditionally, we have the piezoelectric wires from Abbott and Phillips, which have an asymmetric core construction, which unfortunately leads to poor torqueability and poor wire performance. Increasingly, some people have moved on to the fiber optic pressure wires, which have a different core. However, they still have an inferior wire performance and still lead to the risk of loss of position when you pull back the wire. Unique amongst our FFR assessment options is the fiber optic microcatheter, the ACIST catheter from ACIST, which allows us to work and measure hemodynamics over your best workhorse wire. The FFR catheter has a minimal crossing profile of 0.022 inches, or about 2.5 times the diameter of a regular coronary wire, so it's very minimal, and it measures the hemodynamics 5 millimeters away from the tip of the catheter. There have been multiple improvements in the ACIST catheter, which have a smoother entry profile and improve flexibility by reducing the size of the measurement segment. We were participants in the ACIST FFR study, which showed in over 200 patients that FFR from the microcatheter and FFR as measured from a pressure wire are comparable with an area under the curve of 0.94 and minimal mean differences. There was a reduction in clinically significant drift, meaning any drift of greater than 0.03. So there's less drift with the microcatheter than with the pressure wire. More recently, we were able to show that the non-hyperemic pressure ratios could be equally measured with the microcatheter, with DPR from the microcatheter being equivalent to the IFR in the wire, or at least comparable in most cases, with the R value of 0.92 in most cases. The importance of the pullback demonstrates the importance of using a microcatheter. Increasingly, we think of coronary disease not just as a focal disease, but also as tandem lesions and also diffuse disease. So much so that differentiating diffuse from focal disease has become the mainstay of hemodynamic assessment, as epitomized by this pressure pullback gradient from recently published in JACC. Diffuse disease is better treated with medical therapy or bypass surgery potentially, whereas focal CAD, if it can be identified, is best treated with stents. Pressure pullbacks are also useful for checking for drift and normalization and defining what is hemodynamically normal to normal segments. The challenges with wire pullback, every time you try to measure this pressure pullback with a wire, is that you're losing position. Trying to rewire through stents or tortuosity can often be quite challenging, especially with wires that are constructed poorly. Also, post-PCI, you'd like to measure the hemodynamics to confirm your work. Increasingly, we've recognized that recurrent angina occurs after PCI in 20 to 30% of cases, and FFRs have actually been found to be ischemic, less than 0.80, after successful angiographically guided PCI in 10 to 20% of cases. So why are we measuring pre-PCI, but not measuring post? Well, increasingly, people are measuring post-PCI FFR. Post-PCI FFR or IFRs that's low is associated with more MACE, as demonstrated by the 2-year defined PCI study, as well as from a study from Agrawal et al. The FFR search registry of 1,000 patients in the Netherlands demonstrated that the average drift value for a post-PCI FFR using the microcatheter was very low at 0.011, and there's only 3.5% of cases where you couldn't cross again, even through stent struts with the microcatheter, so that's fairly minimal. The study did confirm that a lot of patients, almost half the patients, had a suboptimal PCI result with an FFR that was still less than 0.90, and up to 8% of patients with an FFR that was still less than 0.80 following PCI. And the 2-year study, follow-up of the FFR search study, demonstrated that target vessel revascularization was significantly increased in patients who could not achieve an FFR of greater than 0.90. There's numerical increases with MACE and myocardial infarction and cardiac mortality when your FFR was also low, but these did not reach statistical significance. So how do we put that to work? Well, let me just show you a few cases. We'd like to get to an FFR of 0.90, but sometimes we can't always get there. But the ACIST catheter can help us do so. So here's a case with a middle-aged man with diabetes, hypertension, angina with exertion. A nuclear stress test was read as normal, of course, without artifacts, but his persistence of symptoms and risk factors led to this angiography, which shows extensive tortuosity and stenoses of the proximal ramus vessel, as well as the LAD, which again shows a lot of tortuosity. You could try to take more angiographic views, but these are all at best mildly helpful. You'll need to do hemodynamic assessment here. So we're successful in getting the Phillips Verada wire into the ramus where the FFR and IFR were negative, not unusual for such a small territory. But as you can see, us trying to get the Verada into the LAD, it would repeatedly go into the circumflex or the ramus artery and was unable to make what was effectively a very tight turn. So this is how tight that turn was with a best-in-class workhorse wire, the run-through wire. You can see that it makes a very tight U-turn at the ostium of the LAD, along with tortuosity thereafter. But just by pushing on it further, you're able to advance the run-through wire across this tortuosity with relative ease. So over that workhorse wire, which is again best in class, we were able to place the ACIST FFR Navis wire, Navis catheter across the lesion, and this demonstrated convincingly that this lesion was ischemic with an FFR of 0.67. So naturally, we went ahead and extended the most apparent area. That looked like a fairly good angiographic result. So are we done? Well, you can imagine if we tried to measure FFR again by doing by re-advancing, say, a pressure wire, if we were able to do so, that would be very difficult. We've already shown that we can't get a pressure wire across. But because we had a workhorse wire in place, we could just put in the already opened ACIST Navis catheter and remeasure the FFR. Agarwal showed that 21% of patients still had an FFR of less than 0.80 in his study, and that subsequent stenting and post-dilatation in 91% of cases could increase the final FFR significantly post-PCI. So what did we do? We did the ACIST after our PCI, and we still found that the FFR was ischemic at 0.76, which, we didn't really see anything angiographically, but there's the clear and focal step up in gradient at the ostium of the LAD. And this was evident on IVUS, which showed that the stent was reasonably well expanded, but there's an eccentric and calcified plaque right at the ostium of the LAD at the takeoff of that ramus artery. So what do? We naturally would stent the ostium of the LAD artery very carefully to minimize protrusion into the left main. And after IVUS, we found that the lesion seemed to be resolved. Not being satisfied with that, however, and wanting to demonstrate this, we did go with the FFR Navis catheter one more time. So even though angiographically it looks not very different, the FFR now is 0.91, and only then are we completed with this procedure. So the take-home points for this case are that the Navis catheter can follow the run-through wire through tortuosity that standard pressure wires can't even come close to. The Navis facilitates pullback measurements and repeated measurements when the wire position is not lost. And repeated measurements can reveal that angiographically occult but hemodynamically significant stenosis left behind after successful PCI. And so post-PCI FFR of greater than 0.90 should be the goal, ideally, if we can reach it. That was actually the goal of the target FFR study, which was recently presented at TCT last year, which tested in 260 patients randomized to either physiologically guided optimization or control after PCI, with a goal of trying to get post-PCI FFR greater than 0.90. And anytime they'd found a gradient of greater than 0.5 that was focal or at the stent, they tried to do additional interventions. But if it was diffuse, they did not do that. And what they found was that they couldn't increase the number of patients, because the study was underpowered, they couldn't increase the number of patients who reached the optimal FFR greater than 0.90, but they were able to significantly reduce the number of patients who had an ischemic FFR of less than 0.80. So this demonstrates that FFR PCI, post-PCI is valuable, could reduce the number of patients that have a truly ischemic FFR of 0.80, even if it can't reach the full goal of getting it to 0.90. Just to finish up with a few other cases, this is a case of saphenous vein graft intervention. The patient has recurrent angina after CABG. You see a very focal saphenous vein graft lesion. There's actually coordinate hemodynamics with the resting PDPA being non-ischemic at 0.98, and the FFR being clearly ischemic at 0.69 after just a little bit of intracoronary adenosine. IVUS again helps show the helps be the tiebreaker between non-hyperemia, hyperemic pressure ratios, and hyperemic pressure ratios. And this shows an 87% lesion, focal lesion in the saphenous vein graft. So knowing that this is a focal lesion, relatively easy to fix, we stented it, and then post-PCI, the FFR is optimized at greater than 0.90 or 0.91 in this case. And then I'd like to finish with this case, which had a very large aneurysm of the circumflex and left main in this bypassed patient who had recurrent angina. The run-through wire was able to go through the aneurysm and into the circumflex, but no other vessel, no other catheter, including this IVUS catheter, could not cross this calcified and tortuous lesion. Neither could a volcano verata wire and follow the run-through wire, and neither could an opto wire. So these are all the wires that we had available, and we said, what else can you do? Of course, naturally, you should use this RXI. So even though the IVUS catheter could not cross this lesion, the ACIST RXI Navis catheter could easily cross this lesion and measure the FFR. In this case, the FFR was borderline at 0.79 on 3 different measurements. So given the risk of trying to stent into or rotablate a calcified and an aneurysmal left main and left circumflex, we left the patient alone. So in summary, there's many practical challenges in performing FFR with pressure wires. The wire performance is inferior to dedicated workhorse wires like the run-through. Pullbacks and post-PCI measurements are more difficult because you constantly lose position if you're doing these pullbacks. Catheter-based technology, therefore, has many practical advantages by enabling functional assessment over the operator's preferred wire. The ACIST FFR study validated the consistent and correlation performance of the Navis microcatheter with pressure wires for both FFR and non-hyperemic pressure ratios. And the FFR search registry showed a low average drift rate, a low no-cross rate, and no complications from Navis use post-PCI. And that post-PCI optimization reduced target vessel revascularization at 2 years. So to summarize, Navis microcatheter guidance pre and post PCI is an effective method to optimize your PCI result, and I thank you for your attention.
Arnold, that was great. Thank you. Do we have you live?
Yes, we do.
Yes,
Welcome.
we do. That's great. Good to
you.
see you. Listen, we are here in a full audience. I think there are around 100 to 200 people. I'm here at the table together with Jürgen Lichthart. You know, one of the most experienced imaging technicians in the world, probably. Jürgen, do you have any comments or questions at this stage?
No, at this stage, I have actually one question what wasn't mentioned yet in the presentation of Dr. Seto, especially with the last case where the FFI was 0.79 and you choose to leave this alone. Do you think that this 0.79 could also be induced by the little room that a microcatheter may use more than the average pressure wire?
That's a great question, Dr. Lighthart. So we know, of course, that FFR is has a gray zone of 0.75 to 0.80, and that it really is an area where the operator has a choice. With the ACIST FFR trial, you could show that the average bias was about 0.015. So you could account for the slightly ischemic FFR in that case of 0.79 by saying, well, the microcatheter may be taking up some of the space, especially in this calcified left main, and perhaps the true FFR might be 0.80. But really, this is all within the measurement error of even pressure wires, because often we have a drift rate of 0.02, 0.03, that's still considered acceptable. So if the drift rate is considered acceptable at 0.03, then a mean bias of 0.015 is actually quite acceptable. So I think, like most tools like IVUS and FFR, these are just tools to help your clinical judgment. And so you should not be reflexive in just stenting all patients with FFR less than 0.80.
No. Yeah, I fully agree, Arnold. The ACIST system now also allows you to do a DPR assessment. So that's new. It's a new feature in the console. They introduced that last year, or actually earlier this year, actually. In terms of bias, do you have any data on that? Do you think there is even lower risk of bias with the DPR? Because obviously the margin of whatever you will measure will be lower than with a hyperemic assessment.
Right. So we know that all the non-hyperemic pressure ratios, they have a less spread of values compared with the FFR. So yeah, I would imagine that the bias should be less with the DPR and the other non-hyperemic pressure ratios compared with FFR. So I think that's a reasonable guess. I have to confess, unfortunately, that in the Americas, we do not have DPR for the ACIST catheter yet licensed, but I know in Europe you have that available. So we are looking forward to that.
Yeah. Maybe one final question. So you gave a great showcase of examples in how pre and particularly post-PCI physiological assessment helped you to at least get a better per procedural result. What do you think is needed to convince the community that post-PCI physiological assessment, irrespective of whether you would do that by online angio-based FFR, microcatheters, pressure wires, or maybe even post-procedure spectoc MRI, would be taken as something that people would need to do routinely, or maybe in specific cases? What is needed?
I think that's a great point, Joost. We really have to make it easier for the operator to do what is hard for us. I mean, the inherent bias when we're checking up on our own work, when we see our own angioplasty, everything looks beautiful. We just want to walk away and say, yeah, it looks fine. But we know that 20% of the time it's not really fine. There's actually still some problems with it. And so, how do we encourage people to check up on what they've done? Well, we have to make it easier, either with ACIST FFR catheter, immediately checking it over your own existing guide wire, or like you say, non-invasive measurements, angiographic FFR, any kind of recheck of hemodynamics after PCI that is easy to do, quick. Those are the types of things I think will drive adoption. Alternatively, you could try a regulatory approach and say that you won't get paid until you optimize your PCI, but that I think is more of a hammer than a carrot.
Yeah. Jürgen, any final comments from your side?
No, not from my side, because you also asked my question, but that's the question what I had in mind also. So I think maybe we continue for the rest of the session.
Excellent, very good. So Arnold, we would like to thank you a lot for providing us with your insights on post-PCI physiological assessment.